A lot of familiar faces out there for me, which is awesome. I'm Allison Gregory. I'm a genetic counselor from OHSU, as many of you know. I'm going to let the rest of the panel introduce themselves. And we have questions that were submitted beforehand, so we're going to start with those, and I've tried to group them into sort of categories that make sense, but we're going to also leave time at the end for questions. So if you have a burning question in the moment, feel free to raise your hand, and we can try to do that reasonably, or we can save them more for the end. And I think we'll start introductions on this end with Dr. Wilson.
Hi, I'm Jenny Wilson. I'm a pediatric neurologist at Oregon Health and Science University, and I see patients with NBIA disorders and more generally with neurodevelopmental disabilities. So here today to help.
Hi, I'm Nivedita Thakur. I am a child neurologist and a pediatric movement disorder specialist at UT Health. I actually was at CHOP and recently moved to Houston, so just excited to be here and hope to answer your questions.
I'm Laura Adang. I'm a physician, scientist, and child neurologist at Children's Hospital of Philadelphia. We very sadly just lost Nivi a year ago. We miss her every day. And I work on clinical trial readiness for rare and ultra-rare disorders.
Hi, I'm John Schreiber, Children's National in Washington, D.C. I'm our Associate Chief for Epilepsy and Neurophysiology there. I run our epilepsy genetics program, I run EEG, and several clinical trials for epilepsy, and have been involved in some patients with BPAN. My first time here.
Welcome. So I probably should have mentioned also, you might notice there are a few faces missing from our usual panel here. Dr. Hogarth has been having a health issue, and then Dr. Hayflick had a health-related family issue as well, so we're without them for the conference this time, which is kind of crazy. They've never missed one in all the history of these meetings, but we're going to do it without them, and the good thing is we have a lot of people involved in BPAN clinical care and research now. So I will launch in, and I'm probably going to have Dr. Schreiber start with this one. We had a question about, can seizure activity or EEG abnormalities interfere with cognition? And I would assume either short-term or long-term.
Yeah, so it's a great question. I think one we always struggle with. So there is some evidence that seizure and sometimes EEG activity can indeed interfere with development and cognition. It's a bit hard to tease these things out sometimes because quite frequently we are changing medications around when someone is experiencing an increase in seizures, and sometimes it can be hard to separate out what are the impacts of the underlying developmental abnormality, the genetic change, what's the impact of the seizures or the abnormal EEG activity itself, and then what's the impact of that abnormal brain activity or the EEG. There is this concept that people may have heard the term of a developmental and epileptic encephalopathy. The notion there is that you have both the underlying disorder, the underlying cause, and the abnormal brain activity that's contributing to worsening cognition or development. So that is something that we do try to address, and we can find that improvements in cognition can follow improvements in seizure control. Although it's always a really hard balance to achieve between trying to reduce seizures and then limit side effects from medications, which can also have significant cognitive impacts. I'll talk about this a bit later, but we do try to use medications that have fewer side effects in general, and there are some treatments that may help to mitigate those things more than others. But it's a constant struggle. The last thing I'll say about this is there's even in DEEs or these developmental and epileptic encephalopathies where we can obtain complete seizure control, although we can see some improvements in cognition and development, it still doesn't completely ameliorate that. Doesn't fix things completely.
Thank you. Do you guys have anything to add? Okay, Jenny.
Well, I'll just jump in and say that, there may be some kids out there who don't have that many seizures, and it's not clear that the seizure burden is actually impacting them developmentally, and so certainly it's a case-by-case basis, and it's not a rule that you need to eliminate every seizure, even if we could.
Okay. I'm not going to direct this to any one of you. You can decide who best to answer it. Question about recommendations for specific alternative and augmentative communication strategies, and I would say maybe for young kids and for adults.
I mean, I can talk generally about it. I think, again, it's going to be person specific. So usually there are low-tech and high-tech approaches, and that may depend on the individual person and where they're at with their learning skills and their cognition, whether they can actually look at a picture and realize that picture represents an object. Not everybody can do that. So even starting just with objects and learning cause and effect is going to be your baseline minimum for augmentative communication. So that may be pressing a button and seeing that something happens and learning that cause and effect. And then that can then translate to like yes and no, or two choices, a teddy bear and a video, and they get to choose one or the other. So that's kind of your foundation. And then you have to think about access. So how's a hand function, and are they able to physically, and maybe they have okay function, but they're busy with using their hands to do other things like repetitive movements, and so they're just not going to use it to touch a button or touch a screen. So then we look at vision. Well, you can look at feet too, but that's not always practical. But you can look at vision and think about eye gaze. So can they direct their vision to something they're interested in? And you don't have to have perfect vision to do this. If you can direct your vision or direct your gaze, then your head movements are relatively stable, then you may be a candidate for eye gaze. But you have to be sitting in a spot to do it. So it's not practical for walking around and talking to people. So this is where you need a good team of therapists, and sometimes that's a speech therapist, but may also include an OT and a PT to help with the other components of technology. And those specialists are out there, but you have to look for them and get that evaluation done.
I think the only thing I would add in on that is I love augmentative communication. I think giving our children as many ways to tap into communication is incredibly important. I think one of the places that I see families worry is if I provide a language board or augmentative communication, is it going to slow down other realms of development? And that's not true. Children will communicate and develop skills if we show them that communication has value and causes things that they want, like they want a cookie and we bring them a cookie. It's only going to reinforce their language development skills. So it's okay to use language boards and language devices. It won't slow them down. I think the other thing that's really important is consistency. Sometimes families can get a language device for school, but they don't have one at home. And that's not teaching our children that the way they're communicating has value in all situations. So when it's feasible, and I understand and acknowledge insurance is oftentimes a horrible challenge with this, if you can have a device at home too and show them that you also are going to use their language device, right? So we don't have to speak at our children and expect them to receive information they're going to give us in a different way. We can use language devices to communicate back and forth with them too. Again, reinforcing the good behavior of using multiple modalities to get your point across.
And the only last thing I would say is trialing. So if you do work with a therapist, these are things that technology that you can trial. It's important to see whether you feel like it's going to work, because a lot of times it is a lot of investment and getting the insurance. So try to see, sometimes they have a loaner or things that you can try out, and if it seems like it's going to be something that's going to be a good solution, then to pursue it.
Thank you. Okay. This next one I think we could talk about for the whole remaining time, but we're not going to. The question is, how does cognitive function typically change over time in BPAN, particularly in relation to executive function, attention, and memory? And I think part of what's driving this question is how can people like speech language pathologists adapt or help during different phases of this? Somebody want to take that on first?
Yeah, I'm happy to talk about it from our CHOP natural history study. We've been following cognition and attention in children for several years now, and we see that it's less so a decline in the early years and much more of a stabilization. So children are failing to gain new attention skills over time. And so what it's meaning to do is every year with our IEPs, or those individualized development plans, we're having families go back to their school and just constantly adapt to the child, not expecting necessarily that growth and change is going to happen in the way it does in children that don't have BPAN. And so I think we have studied by far the children in the first phase, or in the first decade and a half of life. And so what we've seen is, again, a gain of skills for several years and then really a stabilization.
And then they become adults, and then oftentimes we see a decline. So that's the other piece of it. But absolutely, there's progression on their own timeline and their own pace up until that deterioration that may happen in young adulthood.
I think the only thing I'll just say is, just on that note, these are generalizations that we're seeing. I think it's important to keep in mind that I think we all have seen different spectrums of it. I think for a lot of families, that second phase is a really scary thing, especially when you have little ones that have been diagnosed with BPAN. I think we're not quite sure, and I think we have to better understand it. So I think that's the other really important thing, that changes may be happening, but there is a lot of variability, and we need to understand that and hopefully come up with better ways that we can give families information as to what we see the trajectory may look like. I don't think we're there. I think we're still gathering information, but I think that's why this is so important, because I think things can be very individualized. And so I know for a lot of families that worry is there, but hopefully, I think, and Laura can say,
I agree in full.
that there is,
thank you, Nivi.
There is some information that we really need to gather that I think is going to help us better understand that.
Yeah, I feel, and Jenny, correct me if you feel differently, I almost feel like we have an elephant, and one of us is looking at the tail, and one of us is looking at the trunk. And I actually am quite positive that not all the children that I meet who are on the younger end of the spectrum will end up having the deterioration phase, right? With next-gen sequencing, genetic testing is more available, and we're identifying more and more kids every single day. What I don't know right now, and one of my main research focuses is how do I meet a baby and predict what the next 5 years, 10 years, 15 years is going to be? Incredibly helpful for preventative care, talking to families, family planning. It's also essential for clinical trials, right? And as we're starting, and thank goodness in the coming years, we're going to be in a space of therapy development, and we're entering into an explosion of medicine and technology now. But we really have a key gap in our understanding of how to say, this child, their trajectory is one of mild disease, and they will never have a second phase. And this child, we want to be extra protective of or monitor them closely because we think they're at higher risk. And I will say, I personally do not have the tools yet with the science that's out there to help to do that early stratification.
Yeah, I think those of you in the room who are in BPAN Ready at OHSU, which is probably a lot of you, can appreciate the kinds of questions that we ask you every 6 months, kind of what we put you through. And there is a different set for 10-year-olds plus, because we're trying to explore this period of regression question. It's not a perfect study. Ideally, you'd start at birth and just watch somebody their whole life to understand the natural history of this, right? But we're on a timeline here, or time crunch. But we are enrolling people of all ages. So we have adults who get diagnosed during that regression period, where we can at least tap into them then and see how it goes from there moving forward. So we're trying to cover the whole spectrum by letting anybody enroll at any age and follow them from there and see what happens. So that's still an ongoing project too. Let's see. So next, there were a couple of questions about behavior, and I think they all can be kind of rolled together. some people asking about crying or, periods of screaming for hours on end, behavior management, what can people, or how to approach managing things like stimming, screaming, self-harm, mood swings, trouble with transitions, tantrums. What is the approach to this? What are the different options, including like SSRIs, other medications, or therapies like ABA? Maybe you can all kind of share your experience with that.
Yeah, it's a really tough topic, and again, not a one-size-fits-all. So I think generally speaking, kids who have like behavior challenges are not trying to have behavior challenges. There's something that's driving it, and maybe it's something they're experiencing, discomfort, being anxious, or maybe it's because their brain is different. And sometimes those behaviors are modifiable by using behavioral interventions, and so if there's something that tends to trigger it and a certain way people respond to it, there's the possibility of behavioral intervention. So that's kind of the first thing I think about. Is this random, or is there a pattern? If there's a pattern, I'm like, yes, okay, this is a candidate for behavioral therapies. And then trying to find those behavioral therapies or specialists who do that is a whole nother ballgame, but sometimes applied behavioral analysis is the way to go, which is therapy that's approved for children with autism, but works for behavioral challenges for anybody. It's not specific for autism. And sometimes insurance will cover it. So some kids with BPAN may have a diagnosis of autism and be able to get ABA therapy that way, but some insurance companies will cover ABA therapy if there are self-harm or injurious behaviors that are happening even without an autism diagnosis. So there may be paths to getting that therapy. And if ABA is not an option, then there are other behavioral specialists who may be able to help. But I think everybody wants to avoid medications if they're not needed, and if there's a behavioral intervention, that's certainly preferable than doing a medication. The other thing to look at is, again, what's driving this. If there is something medically driving this, like there's anxiety or the stomach aches or whatever, you have to be a great observationalist and work with your physicians to try to think about those things. Can we treat something underlying? So that's where an SSRI might come in if you're seeing anxiety, but it's a little bit of a puzzle at that point. And then there are some kids where there's just no pattern, and then if behaviors are random and it doesn't seem like a behavioral intervention is going to be effective, sometimes we do use medications that just kind of decrease irritability, and that's an option as well. And I will say sleep is always going to be a factor here, and if you can address sleep, then that's always going to be like your number one thing to do. Like if there's poor sleep behavior, kids are not getting enough sleep, that may be the most important thing to address. Positive.
Those are all great points and really important, as you mentioned, to exclude other medical causes too. I feel like we see a lot of constipation and medication side effects as well in kids with BPAN and other similar disorders. So important to consider those things when you're looking for a reason for irritability, particularly in a kid that can't really communicate effectively. And then, sleep is key. And there are medications that can sometimes help with that. There's medications that can make that worse. And other things to consider as well. So sometimes it can be helpful to engage other specialists in this treatment as well.
I think the only other thing I would add, and I agree with everything that was said, would be talking to occupational therapists about sensory stimulation. Sometimes children are overstimulated or understimulated, and so depending on the child, your occupational therapist can help work through the ways to help your child self-soothe. Sometimes it's wearing headphones if they're getting overwhelmed with noise or sounds or knowing situations, again, that can trigger outbursts. Some of our kids love vibrating mats and toys and things like that. Again, getting more sensory stimulation sometimes is helpful. It depends on the kid. And so OT would be the ones to reach out to for that.
One other challenge is repetitive behaviors interfering with function. And I don't know that I have a clear answer for this one, but I see this where the child has developmental delays and you're trying to get them to use their hands, but they're so busy with their repetitive behaviors that they're not using their hands in a functional way. So it may not be harmful, but it's kind of impeding their developmental progress. I don't have a great solution to this, but certainly working with therapists to try to motivate children in various ways to use their hands functionally. Practice makes perfect. That's how we learn. So if you can motivate them to try to use their hands functionally by whatever motivates them, then you might start seeing more progress. But I think that's a tough one.
Okay, thank you. Appropriately, I think families with BPAN are always looking for the next thing. Is there something different we could be doing, something extra, something special? And one of the questions submitted was whether or what the role might be for chiropractic treatments or care in BPAN. And I think that could be a big spectrum, so this is kind of a difficult question to ask. But do you want to share your thoughts or experience with chiropractic care in this population? If anybody has any experience with that?
I will only just say not the neck.
I think if this is something that you're considering, you want to make sure that the person that you do go to has experience working with kids and kids with neurological disorders, because oftentimes it can be traumatizing as it is. So I think it's important to get good recommendations and make sure. I always tell families, if you want to try on yourself first before your child, that may be a good way to make sure. It's just, I think there's so much variability. I think we do anecdotally hear from some families, whether it's things like acupuncture, like where there's pressure points, or things like chiropractic, where there's benefit, but I think the key thing is that you're going to somebody that you feel that you can trust and that has that experience. So I always say try it on yourself first before you try it on your child.
In many children's
Not
hospitals,
the neck.
not the neck. Many children's hospitals now have integrative health clinics, and so I know at CHOP we have, you can get acupuncture, you can get massage therapy, you can get aromatherapy and things like that. I will name, I'm not sure our children with BPAN would love some of those things, but it would just depend on the kid.
Okay. I'm going to shift a little bit. I tried to, so we had clinical questions like we've been covering. We also had some questions about research and, treatment strategies, what's coming down the pike. So I'm going to shift a little bit. But one question that I think applies to everybody here that was a good one was, how can families, you all work hard, you are invested in us and the research community, you fundraise. How can families facilitate collaboration in BPAN research, specifically trying to encourage bringing institutions together, getting people talking, kind of like everything we're doing at this meeting?
I think these meetings are a beautiful start and middle. We've been meeting together, and I think having so many different voices, we have 4 different institutions up on this table, is a really important step towards this. And I think collaboration does happen, right? So we lead a consortium of 20 U.S. centers. NBIA is part of it. John is part of it too. He doesn't know it, but Children's National is part of it. So, I think we are building something, and together we will overcome these obstacles. I think it will get there.
And I think the nice thing is that there's going to be meeting opportunity for us as clinicians, but also physician scientists, to be in one room to talk a little bit about this. And so I think that also gives kind of a nice platform for us to figure out where we can work together and how we can kind of build some of these bridges and connections, not only during the meeting, but after the meeting when everyone goes back for some long-term planning.
And we've been talking some about clinical trial readiness. I think a big component of that is understanding, as has already been said, natural history of a particular disorder, because it's important to understand what change looks like over time, what would constitute a meaningful change, what things can change, what are the sort of assessments that you want to employ if you are going into a clinical trial, because these things are they're not clear, and they may be different for different people for different disorders. So just coming here, I think, is a big part of this, contributing your time, and a big resource that you all have is that time and that expertise you have on yourself or your child. It's a big part of the process in becoming ready for clinical trials. And also sharing that patient voice or parent voice with the FDA. It's something they consider when looking at potential new therapies. It's a big part of that whole clinical trial readiness perspective.
And the other thing I'll add that might not be transparent to all of you, tomorrow we have specific time set aside, 2 hours for all the investigators, clinicians, scientists to meet and do exactly what that question is getting at, to start telling each other what we're working on, sharing experience, input. The other thing we're doing is having a clinician training session tomorrow for a few hours where we have some early career or even one medical student from OHSU, people here. I mean, this is the only place you're going to see this people with NBIA in one geographic location, right? This is a very unusual few days. So to be able to bring in early career people and let them experience that and learn about them and have like hands-on experiences with a handful of people who have volunteered to come by and help, that's a really impactful experience and one where we hope to kind of get our hooks into some people and get them stuck on NBIA and want to keep working on it. So, moving on. So one thing that Amber had asked that we all speak about, and I think there were some questions about this as well, and this is another big question, but thinking about approaches to treating BPAN in terms of low-hanging fruit, like what can we do as investigators and clinicians to look for new drugs or new treatments, repurposing old drugs, versus something like gene therapy that you read about all the time, versus ASO therapy, which we've been hearing about. So maybe we can all comment on this a little bit. But because they're not here, I will mention that in terms of sort of screening drug libraries or repurposing existing drugs, Apostolos Papandreou at UCL London, who was at our BPAN meeting in Portland years ago, but we haven't seen him in person since. Some of you remember him. He has been continuing to work on this in a cell model for BPAN and published something fairly recently, I think in the last year, finally, about his findings, identifying some medications that might be useful in BPAN. So that does give us new things to think about, or potential clinical trials or something to use in the mice. So that is one approach. And then there are these sort of more exciting, fancy, gene therapy, ASO things to talk about. But maybe you can all give your perspectives on how we pick which one to use and why and in what scenario, those kinds of things.
So I'm just going to bring up an example that I think is helpful for me. So I work in a condition called ataxia telangiectasia. Some of you all may know this, but called AT. And there's currently a clinical trial going on a molecule called N-acetylleucine. And it's very interesting because the initial data suggests that it can be really helpful in ataxia. And so it's been FDA approved already in Niemann-Pick disease, but it's being currently studied. There's a clinical trial. We're enrolling patients. But I always like to look at what is going on in other rare diseases that have symptoms that can overlap with our NBI disorders, and in this case, BPAN. And I always think, could theoretically what they're using this medication for in this condition be applicable to what we're doing and what we're trying to help our patients? And so I think that is a really useful area as well. I think there's a lot of research going on in a lot of epilepsy channelopathies and rare diseases. But if we can learn about what medications are being used there and why it's being used and whether that could potentially be helpful in other conditions, I think that can also help from a symptomatology standpoint. So that's one thing that I think we should continue to do. And then I think I'll let other folks speak about gene therapy.
Okay, I'll talk on gene therapy. So I think we've been looking towards really a definitive treatment for BPAN. And I think that that is not in exclusion of having drug repurposing strategies, and there's Dr. Knowles in the audience who's working towards therapy development too. I think we need lots of goals on target, right? I think if you focus on only one treatment avenue, the chances of failure are higher, and you also might not meet the needs of the entire community. And while I will say in 20 years, where I hope we are, is we have newborn screening for BPAN. I know in an infant what form of disease they're going to have, and if they need a definitive treatment, I can give it to them, and it's as close to a cure as we have. But that won't be the right fit for every single person, and that's also a long road to get there, right? And so making sure that we're focusing as a disease community on keeping our options open and working towards lots of different treatment options is going to be essential. And creating shareable and renewable resources and publishing frequently and getting our information out there and making it so that as a disease community, we're contributing and continuing to keep that momentum going is going to be really important. I will say I'm putting my eggs, because I can't hold all the eggs, nor do I want to. My one egg I'm putting into gene therapy. And it is something that we have a lot of experience with at CHOP, both from a development standpoint, a safety standpoint, and a trial design standpoint. It is also a disease I think is amenable to it. Not with the existing ways we have to get new genes into cells, but there are new technologies, including some where they took all of the naturally occurring forms of gene therapy, and this is the AAV therapy. And Dr. Bev Davidson at CHOP passed it through monkeys over and over and over again and found these modified or novel forms, and she found hundreds and hundreds of them that went into the cell types that we needed to get into in BPAN with greater efficiency. And so where we are in the process in the early stage is building that tool, right? And so Dr. Becca Ahrens and I are partnering together, and she's starting to build that tool. And then we're going to try it in the mouse models, because we have a surplus of mouse models in BPAN, which is wonderful. I think we have 6 or 7 mouse models. I will name, none of them are perfect, but many of them are really good. And so it's taking those, both drug repurposing strategies and gene therapies, and trying them and moving forward. I think the traditional AAVs will not get into the right cells, but I think with the modified forms, we have a chance. And so that's where I'm putting all of my efforts for the coming years.
Thinking about this from the epilepsy perspective, we're just treating symptoms, right? Seizures are just another symptom of this disorder. So it would be, I think we all have an eye towards gene therapy that can be truly disease modifying. And those things are happening now for BPAN and preclinical work, and there's clinical trials now that are ongoing for other forms of epilepsy. We work in one called Dravet syndrome. So, and what we are learning in other forms of epilepsy and other genetic disorders can also be applied to BPAN. So I think you're only going to see the pace of these things increasing.
Yeah, and I can say a few more words about the question about ASO therapy, because that's one that always comes up, and I think, I can't remember how long ago, maybe 5 or 6 years now, it was like really in the news for a while related to Dr. Timothy Yu at Harvard. ASO therapy, without going too deeply into the science, depends very specifically on the mutation one person has. Like the way it works, it's tailored to their specific gene change, and only certain changes are amenable to that. In BPAN, we see a lot of splice mutations, which are sometimes amenable to this, meaning the way that the transcript, the copy of the gene that goes out to get used to make a protein gets spliced together. We see a lot of stop mutations, which means the gene just has a stop sign right in the middle of it, and no protein gets built beyond that. Then we see smatterings of other types. I think ASO therapy works beautifully in some cases for some people, but we did actually submit to Dr. Yu back then a huge spreadsheet of every BPAN patient we had in our database saying, here's their mutation, what do you think? And nothing, or maybe 1 or 2 people at most, jumped out at him as like something that would be really amenable at that time. That was years ago. But I would say as a community, just like Dr. Adang said, looking at all these different avenues, something might work for somebody, it might not work for somebody else. So being open to all that and understanding that, and also sort of where you want to put your research dollars.
I'll speak on gene editing for a second because I feel like that's the hot topic. And my partner in BPAN gene therapy development is the same Becca Ahrens that did the NF1 editing in the liver. That will not work for BPAN. It won't get into the cells. We are decades off from being able to get gene editing into the brain. We will be there someday, but that isn't what we're pursuing. I don't mean to be so frank and honest on that, but I think it has created this groundswell of excitement. It is not ready for prime time for the brain. Things get sucked up by the liver, and that's why these treatments work well in the liver. It wasn't because it was purposefully put there.
Thank you for that. I think
I'm sorry, I feel so negative every time I talk about gene editing because it has brought such a swell of hope, but I would like to put our hope in drug repurposing and gene therapy and less on the gene editing.
Yeah, and I think that's fair because, as she said, the liver is accessible. You can put something in the bloodstream and get it to the liver very easily. The brain has this whole system called the blood-brain barrier, just meant to protect it from things like that. So we have to find ways to skirt around that, which is part of the challenge there. And I see hands about this. Matt.
Just in like 20 words less if possible, you use two different terms, gene therapy versus gene editing. Can you describe the difference between the two?
Thank you. I sometimes get in my head. I only talk to doctors. They rarely let me out in public. So gene editing is when you have a specific spelling change and you go in with a matching piece of information and you just switch out the spelling error, right? It fixes the problem in your cell so that when your cell divides, that change is no longer there. So it's really exciting in the way it permanently fixes that spelling change in all the cells it gets into. But again, it only gets into the liver, which is a huge problem if you have a disease that's being driven by the brain. Gene therapy, for the most part, we also call it gene replacement therapy, meaning I'm just going to give a whole new copy, right? If your copy isn't working, then I'm just going to give you an extra dose of it. You have to be really careful, and it doesn't work for all diseases because sometimes too much of the protein is also toxic. And so as we get ready for gene therapy, that's one of the things we're going to look into. I have hope it won't be a problem in BPAN, but sometimes you have to be really careful about how much you're replacing and also what cell types you are. We are on the fringes of science right now. It's exciting and terrifying, and anyone that isn't afraid of gene therapy and gene editing is crazy and walk away from them.
Yeah, there's a hand back here too.
So I guess I feel like it's important to the newer families. The therapies and things that you guys are talking about, these are not going to change the damage that has already been done, correct? Or will they?
I'm happy to take that, but I don't have to take all the heat. I think it's really unlikely that it would reverse injury. There have been exceptionally rare cases where the gene therapy has allowed the cells to regrow and start developing again in the brain. I think mostly we would be looking for stabilization in older kids or preventing a second phase if we think there's going to be one. But again, my moonshot goal is to find babies. I think that, and John, I'd love your insights on this. I'm a white matter doctor. You're a neuronal doctor. I call you gray matter doctors. With many of the neuronal disorders like epilepsies, you're born with a change with the way the cell was formed. And so gene therapy is going to be much harder because the brain was just formed differently. Whereas we think in BPAN, the early development and early formation appears to be pretty normal. The first couple months, kids have normal development, are doing really well. And so I think that gives us a window of opportunity to do a truly transformative therapy and intervention. I work on some disorders where the children are born sick already. And in those cases, I don't have any hope of being able to have a true transformation. And so I think through natural history study, through the mouse model work, and honestly through the clinical trial, we'll start to calibrate what our hopes are. But I agree, and I'll echo again, I think the chances of fixing an injury and neurologic disease is really low. We will hopefully get there someday, but people have been trying in the multiple sclerosis field to figure out how to get the brain to repair itself. And I will say our treatments, even in MS, which have been around for decades and decades, are still just preventative treatments.
I think gray matter is similar to white matter in the sense that once you do start to see symptoms, and some of the changes can also are not entirely reversible or may not be reversible either. You start to see some impact. You see seizure onset, you start to see impacts on cognition and development. And although there may be a critical period at which treatment may alter that progression or that overall disease course.
There was another question that's, oh, yes.
Just one question. Something came out yesterday from NIH. They've been doing this brain initiative study for the past 12 years, and they've found ways to deliver gene, and I don't know if it's therapy or editing, to the brain. Just wondered what your thoughts were on that. Really.
We were on the plane.
Yeah. I don't know if I have any statements before I actually look and see what you're talking about.
Okay. Well, maybe we can get back to you on that one. Yes.
Yeah, there's lots of different ways to give gene therapy. You can give it in the blood. We know that it actually does get into the brain in low levels. Those don't tend to be the most effective therapies, but sometimes it works well. You can do intraparenchymal, which means an injection directly into the brain, right? You can do it into the ventricles, which are the fluid lakes. And the trial we're going to launch in the next couple of months, we're going to do an intracisterna magna, which is at the back of the head. There's a big fluid lake there. You can also give it down low in the spinal cord. It all just depends on how well the gene therapy tracks to where you need to get it to. And one of the challenges with giving it in the blood or at the bottom of the spinal cord is that you'll lose a lot of your product before it gets to where it needs to go. But then we're balancing this with how invasive the intervention is and if there are risks fundamentally from the injection. So it all depends, and all of that gets worked out in the final phases before you get ready to launch a clinical trial. You look and see if their distribution studies. So.
Yeah, I'll say too, we talked earlier this morning with the BPAN families, and we're working on gene therapy in that area as well. And in BPAN, in the brain, we have a target, the size of a walnut. That's where we need to get the gene therapy. And we think if we get it there, that's going to cover most of what we need to do. I think BPAN is very different in that regard, in that the target is probably much larger, or perhaps whole brain. I don't know, what no. Okay, but bigger target than a walnut, yeah. So that's going to affect how they deliver it. Yes.
Going back to the statement in question about the damage that's already been done and whether or not it's reversible, it's my understanding that there's basically two different aspects of BPAN going on simultaneously, and one is the ongoing damage which accumulates slowly, but then eventually we see it reach a threshold in later adolescence and adulthood where it kind of takes over and causes that second phase of deterioration, and that starts from the very basically birth.
am taking. I'm a glutton. I think that there's a lot of information about the mechanism of BPAN and where the injury is coming from that is very speculative right now. And I don't know. I don't think that the iron itself is a primary driver of why the young girls have developmental differences. I very strongly feel that because there's no iron. But you're right, it is an inborn error of metabolism and particularly of autophagy. And so the differences in how the cells are functioning and working is happening very early. There's a group at CHOP that is actively exploring how the mitochondria or the workhorse, the energy center of the cells are affected in BPAN. It also might be what we call an epiphenomenon, which is secondary. Really, in all neurodegenerative disorders, the mitochondria are really unhappy and work differently. And it's not driving it, it's just a phenomenon on that. So I'm interested to understand more. I guess as a physician scientist, my goal is to temper expectations. And I can secretly hope along with you that it blows us away. But I never, ever want to sell hope to a family that it's going to fix something. Because when we look at disorders that have been treated before, it hasn't helped in those situations. And so I'm going based on that. I also have hope, but I want to make sure that I'm not telling that to families who are, I'm saying it to a friendly room, hopefully. You guys are really vulnerable. You're doing this because you have a love of a family member, a child that's affected. And I would be wrong if I told you I thought it would fix it. I can say I hope it does, which is a slightly different thing. And if it ends up being spectacular, I will be the first one to say I'm wrong and I was really happy I was wrong. But when you look at gene therapies for brain, they have not, with one exception I can think of, they have not been able to reverse that injury. But again, I hope I'm wrong.
And I think in general with gene therapies, we know that the younger you give it, the better kids do. And I think it's really hard to tease apart the mechanism because we don't totally understand it and what's permanent, what's not. At least I think that's difficult, and how that translates to the clinical manifestations is so complicated. I don't think anybody can really do that and then therefore predict what's going to happen. That's not a question that can be answered. But I think in general with gene therapies, the younger the better, and the older the person is, the farther along with the disorder, the less benefit they get. I think that we can say.
In the back.
So someone else is taking this one.
Is anybody doing the gene therapy currently for BPAN kiddos? Like, is it even an option for us?
It is not. No, we are years off. I took, oh gosh.
Yeah. Go ahead.
I'm gonna switch gears a little bit, I think. So I've been paying annually for cord blood banking for my BPAN child. What should I do with it? Like, how can it be helpful? Like, should I just, I write the check annually and I just kind of don't know why? It's just like, is it something that's being used? Is it just a check I write every year?
Oh God, okay. All right, I will take this one, unless you guys want. So,
I'm not attached to the answer.
so I'm really, this one makes me really confused sometimes. So if a child is affected and you're saving the cord blood, it's sometimes to what end, right? But I will say what cord blood does is it replaces a type of cell called microglia in the brain. And I didn't talk about it because I don't know, I don't feel like dominating too much, but one of the things we are worried about is that the microglia are driving this disease to some part. I think the neurons are the main cell type that's affected. They're the number one gene or cell type that expresses this gene, but microglia actually express it too. And so cord blood actually is very helpful for that. And so there are targeted ways, and we're looking at microglial replacement directly as an alternative approach for BPAN as well. So again, lots of goals unshot. Hopefully we'll get there. Yeah, absolutely. I won't say to not keep it because it always feels bad. If I had met you beforehand, I probably would have said, I'm not sure if there's any evidence we would use it. It's hard to have it in hand and want to get rid of it, though. I guess that's my mush mouth way of saying. I don't know. Depends. I mean, they're for profit and they're trying to make money. And they prey on families that are really vulnerable at a time when you're postpartum and you have no wits about you, right? I don't know. Wait, I don't want to be the only one that answers that controversial question.
I was just going to say, when you chose to bank cord blood, you didn't know your child had BPAN. You did it for other reasons, right? I mean, I think people generally, as Laura said, you're tired, you're postpartum, you're hormonal, and it seems like a good idea. And maybe it is. I think people do it as an insurance policy almost. It's just an insurance policy against something bad happening in the future, a rare cancer, some other application we don't know about at the time. So then it just comes down to personal, your gut feeling. It's okay to let it go if you feel like you don't need it anymore. You know, I wouldn't feel badly about that.
Thank you, Allison, for taking some heat.
I'm taking some heat. Yes, right here in the middle. Go ahead. You're the only one with your hand up.
I actually got the microphone earlier. I raised my hand before. Hi. So you're talking a little bit about cell types and where the expression occurred. Been reading a lot about work on astrocytes. How does that cell type play into BPAN expression?
I mean, oof. Come on, guys. Come on. Yeah. So if you look at the Stanford group, actually has a really nice tool where you can look at the expression of almost every single gene across all the different brain types. It is expressed in really all cell types to some degree. And so the beauty of gene therapy is it's kind of dirty. It gets into a lot of cell types. You can target it to one. You can enrich it in the cells you think are most affected, but like the new modified gene therapy will hopefully get into, to Allison's point, many of the cell types with an enrichment in the cells we think are most affected based on both expression and also the areas of injury. And so I think cell type and localization or where in the brain matters a lot for gene therapy. I think the other thing that's really important to know is that we will find out a lot more. The gene was discovered years, decades, how many years ago now? 12, yeah, 12 years ago. We've come an incredible way. Really, the firm link to autophagy is a fairly new discovery, and so we will be learning a lot about the role of this as a protein, which organelles we need to get it into, which cell types. I think the coming years are going to be just an explosion of knowledge. I'm really excited. It's going to be, hold on. So the answer is yes, astrocytes to some degree, not a primary player, probably a secondary player.
Thank you. I hear a lot of talk about crossing the blood-brain barrier, that seems that's one of the main issues in finding something to stabilize or reverse treat. Is there any substance currently that you know of that crosses the barrier that you could attach something to do that crossing?
I'm sorry. I want to be glib and say yes, my needle. So I think one of the ways we can circumvent the blood-brain barrier is by delivering the gene therapy or the therapeutic into the space we need it into. I think there are many good reasons to do that. The blood-brain barrier is certainly one of them, but the other is our goal is to give as small a volume a little of virus or vector as we can. Side effects, and I will name life-threatening side effects of potential death, we think are dose-related. So is cost. And so if we're going to get to the place where I hope we are, where we can do gene therapy under $1 million, right, that would make it infinitely more accessible and scalable. Right now, we're not in a scalable. We have the technology, we don't have the scalability. And that's okay. All technologies go through this. If we think about how much chemotherapies cost 50 years ago, we are at the very beginning stages. The costs of gene therapy are not scalable at the moment. 2 of the 9 approved gene therapies are leukodystrophies, which is my area, and the most expensive drug ever is one of my drugs, right? Lenmeldy, which is for MLD, is a lentiviral-based vector and is $4.25 million. I know. And so if we can start to do vectors like the one we are going to try at CHOP, that we can use much lower volumes, safety gets better, cost gets better, right? I can get it in a targeted way, and it's not just getting sucked up by the liver and all the other places that these gene therapies tend to go. Your systemic side effects and that inflammatory response you give, you're giving, at least with the AAV therapies, the dose equivalent of tens of thousands of times more than what you would get with a viral load compared to COVID, right? Think about how sick people got from the inflammation with COVID. And so that, I think, is the big place we're going to be changing, is giving smaller doses in the right spaces that go to just the cells we want them to. And hopefully we can mitigate some of that risk and life-threatening risk from the inflammation. Again, you should be scared of gene therapy. Excited, but also scared.
I don't want to know anything about gene therapy, so you're off the hook. Our daughter is 41 years old, and she is obviously way past phase 1 and in phase 2. What we're seeing now is more added things like Parkinson's added to the diagnosis of BPAN and Alzheimer's. Amanda is developmentally maybe 3 months old at this stage now. Now, she did go up and down steps and everything in her early years, and she's now tube fed. Our question is, are y'all doing studies on the older people? Are there many older people? I mean, I don't have many parents that I can say, okay, here's where we are, because our lifestyle for Amanda is in, and I'm so grateful for all these early diagnoses for these young parents that know early on, because we've only known for 10 years. But we're grateful to know. What's going on for our adults?
I can speak to that a little bit. So at OHSU, when we found that gene back in 2013, we actually found it in a group of 15 to 20 adults. At the time, we had no idea what BPAN looked like in little kids, none. They were all adults, and we had recognized, okay, there's this little category of adults who looked one way when they were kids, but then had this regression, and they all looked very similar, and that gene popped out like in a few weeks. It was crazy. So the adults are really important to us. They continue to be really important to us. And in our natural history study at OHSU, which is different from the one at CHOP and not competing, but collaborative, and I think we tend to maybe gather more information about the older ones. I'm not sure about that.
No, we have all comers.
Okay, never mind. So at any rate, we have a portion of them who are adults or older, and we do continue to follow them every 6 months, and we have a separate set of questions that we ask about them. I think we also have now 3 brains. So brain donation is something we talk about in these rooms from time to time. We've had 3 different patients who were adults at the end of their lifespan whose families had the wherewithal to think about that and to follow through with it, and we have brain tissue from all 3 of them now. So we are looking at a small study with our neuropathologist at looking at the clinical correlation, the MRI, and the brain pathology. I don't know if you want to say anything else about that. But they are important to us. We are still trying to study it. I think part of the challenge, too, is there are probably a lot of adults with BPAN out there who are not diagnosed. And any of you, the few in the room with adults know this. It's because they've been stable. They've been stable for a really long time. And until they hit that regression, where maybe they end up at genetics or a neurogenetics clinic or a neurologist who decides to do genetic testing, that's like the second opportunity to look for BPAN now that the gene has been discovered. But I'm certain there are many out there who have just never been tested. Yeah, so we're still working on that part. There's a question way in the back.
Oh.
Can you hear me?
Yep.
A little bit of an inverse to this question. So you hear about the typical trajectory of the disease where there's the regression kind of in early adulthood. I've been seeing a little bit of, every case is a spectrum. When are cases where you see a very early regression? Because I have seen a few of those here and there. Is there a link or is there a pattern where you see kind of early regression?
I'm happy to take that on, and then maybe you guys can jump in. So I think we are in a moment of phenotypic explosion for BPAN. And what I mean is what we thought was BPAN, based on the original studies, is really ultimately very different. Around 20% of our cohort at CHOP are boys, who are a huge range, right? I know I hear a lot of, oh. You find what you look for. I'm sure that in the Parkinson's clinics and the Alzheimer's clinics, we see many people in autism clinics. I'm sure there are many girls and boys that aren't diagnosed. We have boys with mild autism in our natural history study, right? I think that the answer is, have I seen early regression and early features? Absolutely yes. In my experience, it has been more when children have had very hard to control epilepsies and seizures in the early phase. And again, to Dr. John's point, I'm not always sure if it's the seizures that drove the challenges or the disease itself that was the underpinning as to why. We have a lot to learn. We're going as hard as we can. We've been working on it for me less than the OSHU group, but you guys have been working on it for 13 years. I think I'm now at 6, right? Like, we're trying. We'll get there. I would like to reframe. I think we are all anxious for answers and definitive treatments and things. As someone who has come into this space, we have made incredible strides. Like the fact we have multiple natural history studies, we are publishing things constantly on this disorder. We're now talking about therapies. This is a space that 2 or 3 years ago I didn't think we were going to be at. So I both apologize for how slow we're going, knowing you guys are thinking about your children and your loved ones, but I also want to celebrate because of this amazing community. We've blown it out of the park. We're just at the beginning, and it's going to get crazier and bigger really fast.
Yeah, I think that's fair. I'll just add, like, of the handful I can think of who had early regressions or, like, Parkinsonism in their teen years, and that's pretty atypical for this, but I think they were pretty severe pretty early on, so there probably is some correlation there. Not a perfect one or one that we can predict or give you a crystal ball for your kids, but something that we've definitely noticed. Yeah. Yoda.
Sorry, I think that person has.
Hi. I'll pass you the mic in just a second. Hi. So how common is it to have a random mutation of BPAN versus getting it from a carrier? And is there research being done on the carrier to help with early detection?
That's a genetic counselor question.
I tried to shift it away a little bit.
It is almost always what we call a de novo, meaning a brand new change. So the vast majority of kids with BPAN did not inherit it from a mother or a father who has that same change in all the cells in their body. It's a spontaneous change. These spontaneous changes happen all the time in our genome. We just usually don't know about them. But it's, the egg, the sperm, it might have been before conception, it might have been after conception. We know that happens sometimes too. Occasionally it is inherited. meaning you can actually test one of the parents, the more often mom, and she has it in her blood cells, or her skin cells where we can see it, sometimes at a low level only. And the implication there is that it's in the egg cells, and that therefore it's more likely to happen again in future pregnancies. But can we test for that before pregnancy with some effort? Yeah. But does that answer your question?
Yeah. Just a side note of it, is there anything that would affect mutation, such as substance use, things like that?
Not anything specific. Yeah, no, I mean, don't use substances. No, I can't point to any one thing. The only thing I can point to, and dads, please don't blame me for this, this happens in other genetic disorders as well. Usually the moms take the heat for this, but there's something called advanced paternal age. So dads 45 and older, we have looked at our BPAN data, and this is a weird roundabout way of picking up on this, but we've noticed a lot of twins. Okay, if you look at the kids here, the families in our database, there are more sets of twins than you would expect by chance alone. And this kept bothering us. We were like, why? And we kind of dug into it about a year ago. And what we found is it was because there was more IVF. Okay, well, why was there more IVF? Because there was more infertility. And eventually we got to the place of advanced paternal age. So we do think that, and we know like achondroplasia, other genetic disorders are more common with dad's age. They even do, recommend an extra ultrasound sometimes in that instance. That's not something you're really going to do anything about, but yeah. Yeah.
Thank you. So I have a question. I know some of the BPANers have epilepsy and seizures, but there's some where there's spiking activity on the EEG, but there's no seizure. And we've been told that there's no medication to give. But that would cause also the cognitive delays.
So probably not. There are a number of studies that have kind of tried to get at this question. And this includes kids with all forms of epilepsy. Some who have very frequent abnormal activity on their EEG. They might only have a few seizures. And there has been no relationship between their cognitive performance and like using medications to treat that. We're actually looking at this in another disorder. There's something called electrical status epilepticus of sleep, where you have like continuous abnormal spiking when someone falls asleep. In some cases, it's pretty rare in epilepsy. It's it's like 0.4% of people with epilepsy will have this finding on EEG, and it's very striking. It has, in rare cases, been associated with worsening cognition. You can actually see a regression. Classically, it's in a kid who's normal to typically developing, and then with or without seizures will go on to have very striking developmental regression, most prominently in language. You do an overnight EEG, and you see this on EEG. In those instances, we actually can see improvements in their language and other cognitive functions with treating that. But that's a very rare circumstance, and I think represents sort of the extreme end of that spectrum. In general, we treat the seizures. We don't treat the EEG, with a few exceptions. And in the cases where this has been explored, we haven't seen a relationship between treating spikes alone, not just treating seizures, but treating the spikes, and any improvements in their development.
Are doctors allowed to ask questions?
Only if you answer them. Yeah.
Hi, I'm an epilepsy specialist from Stanford, Juliette Knowles. I was wondering, along these lines, if you could just give an update. What types of epilepsy are you seeing in children with BPAN in the natural history studies? Thanks.
I mean, I think there's wide varieties. Some kids just have seizures with fever. Some kids have, generalized seizures. Some have infantile spasms. Some have multiple seizure types, myoclonic seizures. I think it just kind of runs the gamut, and runs the gamut of severity too. I think in general, they do tend to improve with time as they hit adolescence. That's fairly consistent, not 100%, I think, but fairly consistent.
Yeah, I was going to say the same thing. It runs the gamut. I will say when children have occasional seizures, not frequent seizures, it is one of the few genetic epilepsies that I know of where there's a high chance of outgrowing it. I have not seen it when children have had persistent frequent seizures to outgrow it, but a very high percentage of our kids outgrow it. I would say, to me, it's by 8-ish. It just disappears. And so oftentimes if a child only has very rare seizures, I will just allow them to get bigger and keep the medication the same. And then when they're 2 years seizure-free, I look at an EEG and look for, again, all that electrical activity. And then we make kind of a risk assessment of saying, okay, there is a chance you might have outgrown this. I am anti-doctor and drug in general. One cannot tell from this conversation, but I think the less drugs you can get away with, the better, particularly if it's not benefiting the child, it's just causing side effects.
You know, and we've seen this in other disorders. You know, sometimes increasing the number of medications just decreases quality of life, right? It may not have the impact, the desired outcome you want. I just, in looking at the literature, I don't have as much experience here with BPAN specifically as these folks do on the stage. But I think it's probably a lot of Lennox-Gastaut as well. Anytime I see lots of, focal seizure types as well, in addition to, right, the more severe cases, exactly. So when you see generalized seizure types, but you can also see focal seizure types in those instances. And I think it is helpful in terms of diagnosis and medication selection there. A lot of infantile spasms as well, again, in the more severe cases. But it's important to kind of pick those apart in particular because the treatment for infantile spasms and the treatment for Lennox-Gastaut syndrome is very different than treatment for other forms of epilepsy.
There's also a pattern that's kind of come out. Some kids will have seizures upon awakening. They may not look exactly like seizures.
And just like Rett syndrome, oftentimes kids can have abnormal movements, even that are interrupting sleep, that aren't actually seizures. And so I think it's really important to make sure we're treating seizures as seizures and just abnormal behaviors, not with anti-seizure meds.
Hi, everybody. So I'm Lena Borbela from LMU Munich, Germany. And I'm a basic neuroscientist, and I would first like to comment what you asked, because I'm actually from the Parkinson's disease field, so I work since about 18 years in Parkinson's disease research, basic research, and actually cases like your daughter's case are very interesting for us, and that's why I also entered the BPAN and also MPAN field, so these are my main research areas in NBIAs about like 5-6 years ago, because I saw some commonalities like Parkinsonism in older BPAN patients. So I'm happy to talk later to you in more detail. But it's important for both sides, the Parkinson side and the BPAN, MPAN side, kind of to learn from each other. So we use iPSC-derived neurons, microglia, astrocytes to try to understand, let's say, the basic behind that. And if I may, so I want to comment on some things here. So the drug repurposing point that you, Nivedita, made about, for example, NAL, so N-acetylleucine, which is maybe an interesting compound to keep in mind, helping in ataxia, helping in Parkinson's disease patients, interesting paper 2024 out. And we are actually also testing this as, again, basic science, cell culture in MPAN patient iPSC-derived neurons. And to your comment, which was interesting for me because I learn a lot here from all of you and from the audience because I'm not clinician, what you said on microglia replacement in BPAN, we also look in iPS-derived microglia from actually BPAN patient samples, and we do see some, let's say, early inflammatory signs. So maybe it's interesting to talk, which comes back to the comment of like bringing research groups together, the comment you had in the beginning. This is exactly actually what we should do, like researchers or clinicians traveling around, trying to make connections, and maybe we all can also talk later more in depth on science to, broaden this, collaboration. Thank you.
I came in late, so I apologize if this has already been asked and answered, but will there be any slowdowns in gene therapy research due to, pending cutbacks in the national health?
Each of that question.
I think there is actually a session on that tomorrow, right? Yeah, so maybe we can save it for then. It's a complicated question. I'm sure we all have opinions about it. But yeah, we'll save it for that session.
May I speak to it for just 1 second?
Of
though?
course.
Tomorrow I am going to be on the panel. I think as rare disease warriors, we are not new to adversity. We're not new to resilience. And I think we're just going to have to lean into those skills more than we ever thought and think creatively and flexibly about how we're going to move this forward without barriers. I mean, we can do this. It will be harder. We will still do it. Okay?
We've been doing a lot of physical exercise for trying to delay the regression, but recently we heard like more exercise gonna cause the seizures. So I want to know the physical exercise against to the regression. What's the relationship? And is there anything we can delay the regressions?
So we may want to talk about this specifically. I'm not sure who told you that if you do physical exercise, it's going to cause seizures.
I mean, too much exercise.
I guess, what is the definition of too much exercise in your mind?
I'm not sure, but we're trying doing like at least 2-3 hours like physical therapies, like a lot of exercise for my kids to develop the physical abilities.
I think, a lot of families do intensives, which is kind of what you're describing, where you're doing several hours of therapy. Again, I'm not sure who communicated this to you, but there isn't anything specific that says if you do intensive therapy that you're going to have seizures. So I think we may have to understand your specific situation to better answer that question. And in terms of preventing regression, I think what's important is to keep active and to do things that keep our bodies moving. That's really important. As a movement disorder specialist, I always tell my families, it's important for us to keep our extremities moving, because once, you start having a lot of those symptomatic issues and you start developing contractures, which means things become fixed, it's a much bigger problem, and you lead to a lot of orthopedic complications that can happen. So I think...
May I jump in for a second, Dr.?
Yeah.
My best friend, Dr. Nivi. Can I compliment that though and say that if and when the regression happens, it was not your fault. It wasn't because you didn't do stretches or you didn't do exercise or didn't do horseback riding that one time. We do our very best as parents to help protect and support our children. And ultimately, we want them to have as joyous and free and pain-free life as we can give them. But until we have treatments, drug repurposing, gene therapy, you name it, I don't know if any parent could stop it once it starts happening. And it had nothing to do with you not doing therapy, okay?
And sometimes exercise can actually be protective against seizures. I mean, there's been some research on this as well, not in BPAN necessarily, but there's certain people can have different triggers for seizures. Sometimes overheating can be one. I don't think that's a big one for BPAN. So there might be individual differences in how somebody responds to exercise, but in general, I would say I think you're going to see much more benefit from exercise than avoiding it. It can even help with sleep and stuff like that also.
Hi. So my question is, which probiotics do you think can help the children the most, especially related to the microbiota? As we know, because I have seen my sister, the microbiota is our second brain, and this affects, my sister and all of the BPANers. So which probiotic do you think is that can help the most?
I think I got most of that, but is your question about if there's a certain probiotic that can be most useful in BPAN? Okay. I can tell you we haven't studied that. I am not sure that anybody anecdotally has an opinion about that. Yeah, sorry. That's...
It's a question we often get, though. I think, not about probiotics in general, but about other supplements or vitamins, or, what might help my kid, or what food should we give them, or, and anything like that. And the answer is that there might be something that exists that's better for BPAN or for your child, but we often don't know what that answer is. I think, people often try to, search those things out. And many times, I think a lot of those searches do probably prove futile. In general, it's best what makes your kid happy, what fits with your life, what you can find in the pharmacy. Sometimes those things are the right answer.
I'm going to tack this on because I'm sure somebody's going to ask it, or I'm going to be shocked if somebody doesn't. Biotin has been getting a lot of play lately in the family Facebook group. Was that yours too, Amber? Okay. There was a paper that came out several weeks ago now, maybe, from Dr. Alcazar in Spain and his research group about biotin in BPAN, and it was in cells in a dish. Those were the studies. These were not on people. They were in a cell model. And I don't know if everybody up here has read this paper, if they have an opinion about it. I can tell you at OHSU, our PhD who runs our lab, Sue Young-Zhang, actually went through that paper for hours, combed through it and then presented it to the rest of us, section by section. And there were some, being delicate, there were some things that methods that perhaps we would not have done or weren't the same level of rigor that we would expect in a publication like that. To be fair, biotin is a safe water-soluble vitamin. There's a recommended dose for kids at different ages. It's something that you can talk to your pediatricians about and give your kids if you want to try it. There isn't in that paper some magical recommendation for an extra amount of biotin you can take, or an extra safe amount, and there is no guarantee that what happened in those cells in a dish is going to happen in a child or an adult with BPAN. So just to be really clear, that's all the work that needs to be done to connect the dots from that paper to your loved ones. I'm sure these guys have an opinion as well. So.
From a clinical standpoint, it might be very hard to know. So if you decide to try it, because there's very low, if any, risk, how are you going to know if it's helping prevent disease progression? Of course, if you see a miracle change, that's one thing, but you'd have to, it may be incredibly difficult or impossible to know, and then are you going to continue it for years without knowing? So I'll just throw that out there. It can be kind of difficult to suss out whether it's effective.
We're running out of time. Amber's 3 minutes.
One, maybe 2 questions depending on it.
Okay. I don't know where the mic is. Okay. Whoever's got the mic, go.
Hi. So my sister is 31 years old. She was diagnosed with, sorry about my pronunciation, static cerebral palsy a year and a half ago. Could this condition be linked to BPAN or a consequence of it? Could we say she could develop other conditions to BPAN?
So I think the question you said was that your loved one has a diagnosis of got a diagnosis of cerebral palsy. Yeah. So that's actually a common diagnosis that a lot of patients that have neurological disorders, including BPAN, get a diagnosis. What's tricky is that CP, it's a clinical diagnosis, and it's based on the fact that you have developmental delay. It can primarily impact your motor development. But the cause of CP usually is because there was an injury that happened very early on, and that injury is not progressing. So when we didn't have a lot of genetic testing, you would look at a patient and you would give them that diagnosis, at least based on the information that you had clinically. Now that we have a lot of better understanding of the genetic conditions, there's many patients that have cerebral palsy as a diagnosis, but really it's that genetic condition that is giving them that CP picture, or what looks like a cerebral palsy clinically. So I wouldn't think of it as a separate issue. It's just clinically what the doctors may be seeing. They've given this diagnosis, but really it's the underlying genetic condition, in this case BPAN, that's driving that.
And there are different layers of diagnoses. So cerebral palsy is a disability diagnosis, and other similar diagnoses are autism and intellectual disability. And those are, it doesn't, irrespective of the cause, you can have that as just a clinical description. So one layer might be cerebral palsy, but the cause might be a genetic condition, or autism, the cause still can be a genetic condition. Really, to determine if cerebral palsy is present, you have to meet clinical criteria. And if it's a progressive disorder, then generally you would not qualify for a cerebral palsy diagnosis. But there's a lot of debate and discussion within the field itself about who should warrant that diagnosis beyond the scope of this conversation.
I know there are more hands up. I'm going to wrap up for now and ask you to seek us out individually or wait for the BPAN research session on Saturday. There will be other chances. And the last thing I'm going to do is make a shameless plug for our biosample collection, which we're doing today only, because we're going to ship it back FedEx tonight to get to the lab by Friday while it's still a weekday. So yes, the Palmetto Club room is where we are set up to do this. It's sort of tucked, if you're facing the doors that go out from the lobby to the parking lot, it's to the right. But you're looking for Palmetto Club, and we've got gummy bears and finger puppets and all kinds of little doodads if somebody wants to stick their arm out. Both adults and children with BPAN, and we're looking for healthy siblings because we always need what we call control samples. That's how we know what to compare them to when we're looking for a biomarker, some of the work that we're doing. Many of you have consented to this already. You've signed the paperwork. All you're going to have to do is help them get their blood drawn. We've got our database open. We know who needs to sign and who doesn't. I would say not everybody go there right now, but we're ready and waiting if you want to. If you see that we're 10 deep, come back in half an hour, we would really appreciate it.
For those who have donated previously.
Come on back again. Yes. Sorry, Dylan. Yeah. Okay. Thank you, everybody.
Guys, I have one comment to make real quick.
We're done at about 5 today.
If you have children in the care room that are using